Now we will invite Dr. Alexander Testa. He's an assistant professor in the Department of Management Policy and Community Health. His research specializes in two primary areas. First, examining the impact of criminal justice system involvement, including arrest, conviction, and incarceration on the health of individuals, families, and communities. Second, understanding the effects of both direct and indirect exposure to crime and violence on health. Dr. Testa has authored over 260 peer-reviewed articles, and his research has garnered support from various local, state, and federal agencies. Presently, he is the principal investigator of a study funded by the NIH developing a hospital-based violence intervention program for victims of firearm violence in Houston, Texas. Dr. Testa holds a Master of Public Policy from American University and a PhD in Criminology and Criminal Justice from the University of Maryland, College Park. Whenever you're ready, Dr. Testa, please go ahead.
Great, thank you for the introduction and having me here. So looking forward to talk with everyone about incarceration and epidemic public health today. You can go to the next slide. Just to give an overview of how the presentation is going to work, I'm going to start with a bunch of charts and graphs to just kind of orient people here to the state of incarceration in the US and Texas so that we're all kind of on the same page. Then roll into kind of talk about how incarceration impacts health and infectious disease, kind of focusing on the COVID-19 pandemic a little bit, and then rolling that into some lessons learned and path forward for both research and practice on how we can combat the contribution of incarceration to future pandemics and infectious disease outbreaks, and then happy to have kind of a discussion from there. So go to the next slide. So also just want to give a note on terminology here. For simplicity, I'm just going to be using terms like incarceration and correctional facilities interchangeably, but I do want to note that correctional facilities vary widely in terms of their size, their design, their security levels, their resources, and if they're managed by local governments, state governments, federal governments, or private industry. It's going to be too complicated to get into all that nuance today, so I'm just going to talk about them as kind of a monolith. Go to the next slide. I also do want to note that I'll interchangeably be talking about prisons and jails, but they are different institutions. Namely, jails are short-term facilities for people who are awaiting trial or convicted of more minor crimes and typically operated by local governments. Whereas prisons are long-term facilities for people sentenced to a year or more, often for more serious crimes and managed by state, federal, or private governments, and often with higher security capacities. So I just want to also clarify that. Go to the next slide. In the United States, there are over 6,000 correctional facilities. Again, there's about 1,500 state prisons, nearly 100 federal prisons, over 3,000 local jails, as well as numerous specialized facilities such as juvenile detention facilities, usually for those under 18 years old, immigration detention facilities, as well as jails that operate specifically on Indian County territories. Go to the next slide. And Texas has over 316 correctional facilities. A lot of counties in Texas, nearly all counties have its own local jail that collectively house over 69,000 individuals. And there's 64 prisons spread out throughout the state of Texas that encompass over 135,000 people, employ over 26,000 people, and run an annual budget of about $3.5 billion. Go to the next slide. So incarceration is particularly important to think about in terms of a public health issue. You may often hear this term that the United States is in an era of mass incarceration. And to give some context of what that means, nationally, there's about 1.8 million people incarcerated on any given day. And the United States stands distinct in its incarceration, both in a historical and a comparative perspective. Go to the next slide. So historically, we are incarcerating, we're not at the peak, but we are incarcerating far more people than we have in the past. Starting around the 1970s, the incarceration rate skyrocketed and it really peaked in 2008 and then saw a decrease. And in recent years, we've actually seen that to start to uptick. Again, still, we are at a rate about 400% higher than our historical norms today. Go to the next slide. And then in comparative perspectives, the US has one of the highest incarceration rates in the world. It had the highest incarceration rate for nearly 3 decades, but we've been surpassed by a few countries like Cuba and Rwanda recently. But we incarcerated about 7 to 10 times higher than the rate of other developed democracies like Canada or European countries. Go to the next slide. And this graph really illustrates this. This is 21 developed democracies, and you can see that the United States has a far higher rate of incarceration, and also that steep increase was a purely American phenomenon, not seen anywhere else in Europe or other developed democracies around the world. Go to the next slide. And focusing on Texas, we have one of the highest rates of incarceration. We actually have the highest number of prisoners by any state in the country. Adjusted for population size, we're about the 6th highest rate of incarceration, currently about 452 per 100,000 residents. And as you can see on here, really the South is the highest rates of incarceration in the country. Next slide. And I just want to kind of also give an overview of the demographics of incarceration. So going to kind of hit on a couple of these. So by race and ethnicity, show the next slide. Incarceration on the left-hand side of this, it shows the percentage by US population. On the right-hand side, the percentage of the incarcerated population. So we do see racial and ethnic disparities, especially among African-American Black populations, who make up about 14% of the US population, but about 42% of the incarcerated population. Less stark disparities among like Latino population, and then white populations are incarcerated at a lower rate than their demographic makeup in the total US population. Next slide. Sex makes up some interesting balances. You go to the next slide. The vast majority of people, over 90% incarcerated, are males in the US. In the next slide. But females have been increasing at a stark rate. So if you go back since the 1970s, the rate of female incarceration has actually outpaced the rate of male incarceration. So we're seeing way more women incarcerated today than ever before. Even so, many more males incarcerated. Age also has some unique features, and again, important for thinking about the impacts of things like infectious disease. Next slide. So the majority of people incarcerated are younger individuals, which makes sense in many ways because crime is a young person's phenomenon. As people get older, they tend to be less involved in crime. But as this graph kind of illustrates, and the next ones will, the age structure of the incarcerated population has been increasing over time. Next slide. So since 1999, for instance, you see the rate of incarceration of adults 55 and older has skyrocketed, whereas the rate for those under 55 has stayed pretty balanced. So there's been about a 300% increase of those 55 and older incarcerated in prisons over the last 2.5 decades. And this is largely due to the fact that sentences are very long in the United States. So people who are getting sentenced to 10, 20, 30, 40, 50-year sentences are aging in prison, not getting released. And you're seeing it influence the age structure of correctional facilities. Next slide. Also helpful to think about the breakdown by states. So this is just kind of an image here, but you actually see that Texas actually has one of the oldest distributions of its prison population. So about 11.2% are 55 years and older, and about 31.1% are between ages 40 and 54. Texas has some pretty long sentences for a lot of crimes, so that 40 to 54 age, a lot of them are just going to continue to age over time while they're incarcerated. Go to the next slide. Also want to talk about, orient everyone a little bit to how incarceration is concentrated geographically, because this has important implications for how we think about epidemic, public health. In the next slide. So what's important to know is a couple things. So the makeup of who's in prison is not equally distributed also across communities. It's heavily comes from a number of communities. So some graphs here from some states with good data that I think illustrate this, but you see this pattern across a lot of the nation. So 17% of the entire Illinois prison population comes from just 6 neighborhoods in Chicago, right? So, and the entire state prison population made up of just 6 neighborhoods in Chicago. You can go to the next slide. All right. And again, to just illustrate that, like with another state here, 6 counties across of all of 6 counties across of all of New Jersey account for just 26% of the state's population, but over 50% of the prison population, right? So again, we see this trend where a subset of micro areas tend to contribute a lot of people to incarceration. And that has big implications because one, it takes a lot of people out of these communities who would otherwise be there, typically young men, and I'll return to that in another way, and typically young men of color. But when people leave prison, and about 95% of people who are incarcerated eventually leave and return, that means there's a big influx of people returning to these communities of heavy incarceration. And so when we start talking about all the disease that is picked up in prisons, it risks this transmission back to a subset of communities with a high density of incarceration. Go to the next slide. Right. And so to kind of also get to that point, those so looking at Newark, New Jersey, another place where we have data, when I talk about that removal of people, right? These 6 southwestern neighborhoods in Newark, right, are missing more than 1% of their residents to prison. So again, it's sucking a large amount of people who otherwise would be in the community out of the community. We can talk later about maybe the pros and the cons of that, but then you kind of look at those incarceration rates, often about 10 times, 5 to 10 times higher than the rate of the state prison. So you get sometimes these state prison rates that are much lower, and you're getting incarceration rates in the thousands. So if you reference back to one of those slides, a European nation's incarceration rate might be like 70 per 100,000, and some of these high incarceration neighborhoods are like 1,200 per 100,000, right? So just monumentally high rates of incarceration. Go to the next slide. So with all that, context in backdrop, I want to talk a little bit about what we know about incarceration, its impacts on health and infectious disease, and then kind of use that to move into some of the lessons that we've learned over the recent years. Next slide. So people who go to prison and jail, even before they enter there, they tend to be in worse health than the general population. But regardless of their pre-existing health conditions, incarceration has strongly harmful effects of the health of prisoners over their life course, right? Conclusion from an article in The Lancet in 2017. And I'll dive into that a little bit over the next slides. On the next slide. So just giving some, overall demographics on prison population, right? Very high rates of health issues. About you see about 11% with hepatitis, 6% with tuberculosis, 6% with STDs, about 1.3% ever had HIV/AIDS. So really kind of higher than expected rates for a lot of health conditions than you'd see in the general population. Next slide. And we'll talk a bit about today also, right? When we did have a big infectious disease pandemic, it really hit carceral facilities very hard. Infection rates, this was from April 19, 2021, so early on in the from COVID-19 pandemic era. Well, not that early on, but see the rate of infection in prisons, about 34 per 100 people were infected, right? Versus about 9 per 100 in the United States and about 2 per 100 worldwide. So I'll get into the reasons why these facilities are so prone to these infectious disease outbreaks, but they're really a hub for epidemic public health. Next slide. All right, just kind of, again, showing this another way, but also bringing in the correctional staff. So when we think about health and disease in prison, we're often thinking about the incarcerated person, but there are staff, corrections officers, nursing and healthcare staff, and other types of staff who go in and work there every day. And those individuals, by nature of being exposed to that environment, also have elevated rates of infectious disease. So you can see the COVID-19 infection rate among correctional staff being almost 3 times that of the general population. But these people go home every single day, right? And so they're also a transmission risk back to their families and back to their communities, whereas the incarcerated person, does not go back and forth each day, but kind of gets released sporadically. Next slide. And then also kind of the relevance for Texas here. So just also due to the sheer number of incarcerated people, right? Texas really kind of stood out amongst the country. Some of the highest numbers of total cases of COVID-19 in the country. Again, going back to the early days of that pandemic. Next slide. And kind of also, tying in a little bit of why this COVID-19 pandemic mattered for both the incarcerated persons, but also the community, touch upon some of the better research that came out during this period. So, right, this one study here showed mortality increased 77% from 2020 to 2019, right? Within correctional facilities across all age groups, with COVID-19 being a major driver. So these higher infection rates in correctional facilities were not just a benign thing, but right, they also translated into a stark increase of deaths that we were seeing among incarcerated populations. Next slide. So I want to also get into some of the reasons why correctional facilities are more vulnerable to things like COVID-19, infectious diseases, and other epidemic outbreaks. Go to the next slide. So a number of features of correctional facilities just make them more vulnerable. So they require close conditions. A lot of people, as we talked about, the incarceration rates really, really high in the United States in places like Texas. It's really, really expensive to build new prisons, and so it doesn't happen that often. And many correctional facilities are operating at or over capacity. In fact, in many places, prisons are allowed to go to 130% of design capacity, and that's considered completely fine. That creates overcrowding where physical distancing is nearly impossible. These facilities often use a lot of shared living spaces like dormitories, cells with multiple incarcerated persons, group dining, all of which bring people together in very enclosed spaces that increase exposure risk, right? You should also note that very few windows due to escape purposes. These places are made of thick concrete walls, again, due to minimizing escape purposes, but really keeps everything trapped in the facility. So for infectious disease outbreaks, really elevates. Again, high rates of pre-existing conditions. So people are constantly coming into these facilities as well as leaving, and that means there's a constant new transmission of people with infectious diseases from the general population coming to the community, right, leading to just this constant churn of spread of disease as well. You will also see some things on here that we can touch about, but acts like tattooing, unprotected sex, and intravenous drug use all happen within prison, all very difficult to regulate. And once something like a needle gets in prison, it's very hard to smuggle in, so it often gets shared. And so we see these outbreaks of things like hepatitis and HIV/AIDS being really spread throughout facilities. Go to the next slide. Also limited access to healthcare. Of note, prison is actually the only place in the United States where healthcare is a guaranteed right. You have universal healthcare in prisons thanks to the Supreme Court decision of Estelle v. Gamble in 1976, which said to restrict healthcare is a violation of cruel and unusual punishment under the Eighth Amendment. However, it does not guarantee the right to quality healthcare. And so people do experience heavy delays in healthcare and just kind of bare bones treatment of services. Go next slide. Right. Also, inadequate sanitation, very limited access to basic hygiene supplies like soap and PPE equipment. Like I said, very poor ventilation, which makes the facilitation of airborne disease, quite prevalent. And there's also a bans on things like alcohol-based sanitizers for concerns that people will ingest it or use it to make their own alcohol while in the prison. And then I'll also talk about a lot of skepticism of healthcare institutions of individuals who are in prison. So a report that came out recently from New York, headline, "My Greatest Fear is to be a lab rat for the state." Talk about the hesitancy of prisoners to take the COVID-19 vaccine, take also a lot of different types of vaccines and medication, right? Given skepticism of the state and the fact that they are under state control with limited autonomy and limited information. Go to the next slide. Then, like I said, there's frequent movement and churning of individuals between carceral facilities in the state and the general population. People are constantly coming in, those convicted of new crimes. Corrections officers come and go every day. About 600,000 people leave state prisons each year and go back home to their communities. And about 10 million people cycle in and out of local jails each year. So tremendous churning. Go next slide. Right. And then just also want to note that that churning of the prison population does affect community health. So you can say here the rate of COVID-19, confirmed new cases of COVID-19 alongside the incarceration rate of a community. And so communities with higher rates of incarceration are also seeing higher rates of incarceration, are seeing more cases of infectious diseases in the community. And I have a couple more studies that will dive deeper into that. If you want to go to the next slide. Right. So the idea here is that people are cycling into prison, catching infectious diseases, cycling back out and spreading it through the community. So this one study here found that the cycling of individuals through Cook County Jail, large jail in Chicago, accounted for about 13% of all COVID-19 cases in the county and about 21% of the racial disparities in COVID-19 due to the large racial disparities in incarceration. Go next slide. Right. And just want to also note here, right, that this finding has been kind of replicated in other places, that the presence of a state or federal prison in a county corresponded with a 9% increase in COVID-19 cases during the first wave. So again, having a prison in your county just put you way ahead. And again, that's because those people who work there are churning every day. A lot of those people who are incarcerated there are leaving, touching base in the local community somehow, perhaps before they return home to their home community. Next slide. Right. And while that is, true of COVID-19, we've known even for decades it's true of all sorts of diseases. This study, using data between the 1980s and mid-1990s, right, found that male incarceration rates were a key predictor of male and female AIDS rates in a given community. So higher communities with higher rates of incarceration, right, had much higher rates of HIV/AIDS, and that just didn't affect the men in that area, given that about 90% plus of people incarcerated were males, but it also impacted the females living in that community. Again, with the idea that males are incarcerated, they go to prison, often they pick up HIV/AIDS if they didn't already have it there through something like tattooing, unprotected sex, intravenous drug use. They get released eventually. They pick up a partner, typically a female partner, and they spread the disease back to the community. Next slide. And then, as I noted briefly, one of the key things, we know that prisons and jails are a huge repertoire of infectious disease, but it also becomes really hard to combat that because there's extremely low trust among this group in the healthcare system as well. You go to the next slide. A study that I did using some national survey data here kind of replicates that. This was done between May and June 2021 here, but we showed that individuals with a history of incarceration who are living in the community were more likely to not follow COVID-19 protection protocols, including using hand sanitizer, wearing a mask, and they had about 3 times the rate of reporting not getting vaccinated or not planning to get a COVID-19 vaccine relative to their never incarcerated counterparts. Next slide. So I also want to use that to just kind of end and then hopefully chat a little bit about some of the lessons that we've learned from this pandemic. So next slide. So a number of things have been kind of learned from COVID-19 pandemic and how things can work better. This is an article here that kind of notes some of the challenges that went through and some of the facilitators. I won't go through everything, but hit on some things here, like some of the challenges. Really strained workforce in correctional facilities, high rates of mental health issues among incarcerated population makes it hard to strategically, work with. Strong data capacity issues makes it hard to track things in these facilities as well. There's also a lack of representation of public health departments and people who work for public health in criminal justice agencies and correctional facilities. Next slide. You go to the next slide. A great article in the American Journal of Public Health. I think these slides are getting shared, so I won't go through all of them, but came up with 10 lessons learned about improving public health in state prisons and making recommendations for key strategies here as well. So ways that when we do see an outbreak, we can minimize kind of the spread there, like making sure there's universal mask use among residents and staff, minimizing transfer of individuals between facilities. Go to the next slide. Right. Number of things. And then I know Taffy does a lot of work with wastewater. So one thing that we've really learned is benefits of things like using wastewater testing in correctional facilities, which have shown effective ways to surveil infectious disease outbreaks and detect them before you start seeing the spread in the population. So places like Atlanta, Georgia have started this and being able to detect COVID-19 outbreaks with wastewater surveillance. Next slide. Right. Also seeing this in a number of other jails like Cook County, Illinois, Atlanta, Georgia, Washington, D.C., all these things kind of showing things. Also want to conclude here by noting that the federal government, through the Bureau of Justice Assistance, has put out guidance on new resources for correctional facilities. Next slide. So just to go through these real quick, some things that they've suggested, peer-to-peer education models. So given the mistrust in medical institutions, training correctional officers or training incarcerated people about basic public health and infectious disease reduction and using them to educate their incarcerated peers. Next slide. There is a large report put out on planning for respiratory pathogen pandemics, which you can read. Next slide. Highlighting here just a lot of considerations that we've learned from the COVID-19 pandemic, kind of summarized into one report. So I want to make that available to everyone in case they don't know it. There's also been a new pandemic toolkit that's been put out by the Bureau of Justice Assistance, which is under the Department of Justice, to help correctional facilities manage it and mitigate infectious airborne diseases. And that toolkit is up online still. Go to the next slide. Oh, and that's about it. So want to make sure we have some time to chat. So kind of went through that a little bit, but hope that's helpful. My email address is also up there in case anyone wants to get in touch after this. But if we are taking questions or anything, well, happy to do that.
Thank you so much, Dr. Testa, for sharing such invaluable insights. And we really appreciate you taking out the time and being here. We'll now open the meeting for any questions that anyone would have. Y'all can put it in the chat. Me or Kristen can manage it, read it for y'all. Or if y'all want to unmute yourself and ask questions, that is fine as well.
Hi, can you guys hear me? Just making sure. Awesome. No, Dr. Hester, that was just some really interesting info. A lot of it isn't, I guess, surprising just because, when reading up on different like behavioral public health aspects, sometimes I think about how does this translate in like the prison system and whatnot. And so something I found interesting or like a correlation is the mistrust in healthcare in the prison system and also the mistrust in healthcare that people of color often have. And, it's not lost on me that you oftentimes have people of color, who are outside, prison systems who also enter the prison systems that come and carry that notion with them. And so I just thought that was very, very, very interesting.
Yes, no, absolutely. And I think that there's a lot of work to be done there to try to overcome that. I think these peer-to-peer education models, while they haven't been well evaluated yet, are a way that would be of interest to try to kind of combat that. I do see a question in here about the wastewater in these things. So these have all been done in local jails. So they've all been coordinated by the counties. Often they've been collaborations between the local county jail, which is usually run by a sheriff's office, a local Department of Public Health, and then oftentimes a university academic partner have kind of been the triad on that. I haven't seen them pop up in too many places, but as I noted, Emory University I know is working in Georgia with it. They're in Chicago, in the greater Boston area, Massachusetts, and in Washington, D.C. So those are 4 jails that I'm aware of from the published research that are doing it. I'm sure that there are some others as well. But also, I'll say a place like Tempe, going back to one of our earlier slides, about 69,000 people are in 252 different local jails in Texas, right? Really hard to coordinate 252 different counties, right? Statewide, which is managed by the Texas Department of Criminal Justice, there's over 130,000 prisoners. So statewide efforts, I think, are needed as well. The question on addressing the health needs of older prisoners, I don't think very well, to be honest. A couple things I'll note there. One, they're struggling budget-wise because older individuals take up a lot of healthcare costs, and as their health needs rise, it's really straining budgets. There's an individual named Bree Williams out of University of California, San Francisco, who I think does some of the best work on this, but one of the things she also notes is how poorly prisons are designed for the needs of the elderly, for basic activities of daily living. Things like sitting on a lot of metal structures, being surrounded by concrete and metal, making fall risks very dangerous, having to often climb on things like bunk beds or elevated surfaces, right? Not being, able. And so prisons were not designed with the needs of the elderly in mind. And as we just see a rising number of older people incarcerated, we're seeing more and more challenges and more costs being associated with this. Also troubling because typically at that age, they're of little public safety risk. You don't tend to get a lot of, 65-year-olds who release and are committing a lot of crimes, and so there is some push to start to transition people back into society, but that also comes with a lot of questions about then how will communities take on individuals who may have been incarcerated for decades, and how will their health needs be met in the community, and what programs might exist for them. So it becomes a really hard issue.
Thank you again, Dr. Testa, for talking. I think I have one more question here in the chat. Destiny mentions,
Yeah.
thinking about how we can incorporate some of those implications of these findings.
Yes, and I know Destiny and our organization's local here in San Antonio, so thanks for coming, Destiny. But and I'd be happy to talk about this. I'm sure you see it a lot in your organization, more. But really, those people who are leaving carceral facilities, coming back into the community, how we can think about organizations that help people transition, get connected with healthcare, build trust in healthcare systems, and minimize the risk that they spread disease back through the community, I think are really important steps. And organizations like Unlock that work with returning citizens, I think, do a lot of great work in that area.
Okay, very great questions and inputs. For the interest of time, I'll be moving on to announcements. Lydia?
All right. So thank you so much, Dr. Testa. I know we a lot of people have more questions. We will be sending out the recording to everyone, as well as the PowerPoint presentation. If y'all need to reach out to him, y'all can contact us as well, and we can collaborate it. We just have a few announcements. First, we wanted to let you all know that our next Vulnerable Population Working Group meeting for Region 8 is scheduled for March 27th from 1 to 2 p.m. You will receive updates very soon on that. And if you are interested in being a speaker or want to share more about the work that you do, or have some projects that you want to share, please reach out to us, as we would love to hear more from you and learn more about your experiences. You can contact, next slide, you can contact either me or Kristen, and we will be happy to assist y'all in any way possible.